obstetrician and gynecologist, and I welcome you all for the next topic, which is insights in management of osteoporosis. As we all know, osteoporosis is a metabolic skeletal disease with low bone density, and it results in bone fragility and susceptibility to fractures. It is one of the silent diseases, and it is a major health problem in Indian women, and according to International Osteoporosis Foundation, worldwide 1 in 3 women over age of 50 and 1 in 5 men will experience osteoporotic fractures in their lifetime. So here we are looking forward to have better understanding on this topic, and we have our experts here. So I would like to call upon and invite our chairpersons. Dr. Kapil Kulshresh sir, he's MBBS MS from MLN Medical College and MCH from University of Seychelles. He's a senior and eminent orthopedic surgeon and exclusive joint replacement surgeon of Eastern UP using computer navigation at his Yashlok Hospital. We welcome you, sir. Dr. Pankaj Gupta, he's Assistant Professor, Department of Neurosurgery, MLN Medical College, Prayagraj. We welcome you, Dr. Pankaj Gupta. Dr. Abhilasha Chaturvedi, ma'am. She's Director, Abhilasha Hospital and Test Tube Baby Lab. She has been past President, Rotary Allahabad, past President, Allahabad Obs and Gynae Society, and past President, IMA Allahabad. She started IVF Lab in Allahabad in 1999. We welcome you, ma'am. Dr. Tribhuvan Singh, sir. He's an eminent orthopedic surgeon of Prayagraj. We welcome you, sir. I would request one of the chairpersons to please introduce the speaker. Thank you.
Sir, it is a privilege to us. He is one of the postgraduate student from the postgraduate department of medicine, Motilal Nehru Medical College. Welcome.
It's a privilege to welcome Dr. Ritesh Kumar at this forum of IMA CGP conference. Dr. Kumar is MBBS from GSVM Medical College 2009 batch. He is MD Medicine from our own college, MLN Medical College, from 2013 batch. And he has done his DM in endocrinology from JIPMER in 2017. He has worked as a consultant endocrinologist in Bansal Hospital, Bhopal, and he has got lots of papers and poster presentations at ITS Con 2015, ISM BR 2015, GSS JIPMER, and ESIE Con. He has got 9 national and international publications, and he is a member of RSS DI and ESI. His special area of interests are diabetes mellitus, thyroid, and metabolic bone diseases. He has been a renowned speaker at various state and national conferences. We welcome you, sir, and we invite you to enlighten us on this topic of osteoporosis.
Thank you, sir. Thank you for the introduction. And good evening, everyone. So today's topic for presentation is insight in management of osteoporosis. So osteoporosis is defined by low bone mineral density and the disruption of microarchitecture of bone and skeletal fragility, and resulting in the increased risk of fracture. So osteoporotic fracture most commonly occur at hip, spine, and at the wrist. And most common cause of osteoporosis is postmenopausal. But we have to also look for the secondary causes of osteoporosis. In that, there is a lot of endocrine causes is there, like endogenous Cushing or ectopic Cushing, or if patient on the steroid, or patient having the thyroid toxicosis, hyperparathyroidism, hypogonadism, which is primary or secondary, or other drugs other than steroid like letrozole. But so before diagnosis, only the primary osteoporosis, we have to look for the secondary causes of the osteoporosis. That is not very uncommon. And the osteoporosis usually occurs because of the imbalance between the bone resorption and the bone formation. So this diagram is showing the bone mineral density across the lifespan. So as we see, we achieve the peak bone mass between 20 to 30 years. Then from 30 years onwards till the 55 years or till the postmenopausal age, there is no changes in the bone mineral density. So just after postmenopausal, see there is a rapid decline in the bone mineral density, especially in the female. But there is also decline in the male, that is the age-related decline in bone mineral density. But that is not to that level as in female, that is because of the deficiency of the estrogen. So what are the clinical manifestation of osteoporosis? So usually there is no clinical manifestation until there is a fracture. And like in vertebral fracture, 2/3 patients are asymptomatic. So only 1/3 patient they present with the symptoms, like they can present with the back pain, or there can be history of height loss. Like if height loss is there for 4 centimeter, if after the final adult height, or if you prospectively measure the height, if there is a difference of 2 centimeter, then we can say this is the spine fracture is there. And the other osteoporotic fracture is like wrist fracture, hip fracture, humerus, pelvis and rib fracture. And rest of the other fracture usually you don't include in the osteoporosis. So fracture itself is a very powerful risk factor for the future fracture. So if any patient like in spine, if one fracture is there, so future risk of fracture is 3.2 times more. And if there is 2 or more fractures, the future fracture risk is 8 times more. The other than fractures, a lot of other risk factors for the fracture, like if BMI is less than 21, if patient is smoker, current smoker, and if there is a strong family history of hip fracture is there, especially in mother and the sister. So as you know, the osteoporotic fracture is associated with the increased morbidity as well as mortality. There is a long duration of stay in hospital and there is a financial burden also. Like in this study, what they have found, hip fracture associated with the mortality of relative risk of 6.7, and if spine fracture is there, mortality risk is 8.6 times. So how we diagnose the osteoporosis? If fragility fracture is there of any these sides like spine, hip, wrist, humerus, rib or pelvis, and it is confirmed on X-ray, so there is no need to do the DEXA scan to measure the bone mineral density. If fracture is not there, we can simply diagnose by measuring the bone mineral density in the DEXA scan. If T score is 2.5, less than 2.5, then we label as the osteoporosis. And if T score is coming osteopenic range, like in between -1 to 2.5, in that scenario, we can measure the Frax score. And the Frax score not only includes the bone mineral density, but it also included the other clinical parameters, like what is the history of steroid intake, family history of fracture is there or not there, alcohol intake is there, smoking is there, underlying bone disease, like if patient have the inflammatory condition, rheumatoid arthritis is there, steroid is there, and previous fracture is there. So all this is incorporated in the Frax score. Even we can clinically calculate the Frax scan without any DEXA scan also. So if probability of major osteoporotic fracture is more than 20% or hip fracture is more than 3%, that is also equivalent to the osteoporosis. See, this is the image of one patient that developed the osteoporotic fracture at lumbar vertebra 2. See the difference in height of the vertebra of L1 vertebra, and this is the L2 fracture vertebra, and this is the L3. So there is a decrease in the height of the fracture vertebra is there. But there is a limitation if you are doing the X-ray to diagnose the osteoporosis, because there is a 30 to 50% bone loss is required to diagnose the osteoporosis on the X-ray, and a lot of subjective variation is there if you diagnose the osteoporosis based on the only X-ray. So osteoporosis we can diagnose simply by measuring the bone mineral density by the DEXA machine. So usually we are measuring DEXA, usually two common machine used like G lunar and apologic. In our institute we are using the lunar machine, and usually we measure at least two sides like spine and hip in almost all the patients. And forearm BMD we can measure in certain condition, like where we cannot measure the bone density in hip or spine, or if patient in case of hyperparathyroidism, whether you can measure the distal 1/3 of the forearm, and if patient is very obese, like DEXA machine also has limitation because we cannot put the very high weight to the machine, because the upper limit, like in our machine lunar, upper limit is 112 kg. So beyond that we cannot measure. So in that scenario, if you can't measure the spine and hip, if we can measure at least the forearm. Now this is the indication of bone mineral density. If woman is 65 or above and the male 75 or above, irrespective of the risk factor, and in younger postmenopausal women and the men between 50 to 69 with the one clinical risk factor for the fracture. So what are the clinical risk factor for fracture? That is include the low body weight and the smoking, any use of steroid, any inflammatory condition. In that we can measure. And adult who have the fracture are at or after age of 50. And if patients having the rheumatoid arthritis, or if patient is taking steroid for the long duration, especially taking more than 5 mg for the more than 3 months, in that scenario we are measuring the bone mineral density by the DEXA machine. Now measuring the bone mineral density is easy, but there is certain challenges when you are interpreting the BMD reports. So basically we are calculating the T-score. So when we get the report of DEXA scan, we are getting the T-score. But how the T-score is calculated? Basically our machine of lunar or apologic, they have reference population of Caucasian data. So the Caucasian data, Caucasian population, how much they achieve the peak bone mass achieved between the 20 to 30 years. From that we are calculating our BMD. So this left side, if you use the Caucasian data, so like in one study from South India, they have found 84 patients having the osteoporosis. But when you calculate from the Indian data, that is the ICMR data, then we have to reclassify it. So the osteoporosis number decreases from 84 to 16. So there is a misclassification, or we can say we are overdiagnosis the osteoporosis if you are using the Caucasian based data that is already built in our DEXA machine. So there is a, if you use the ICMR data, the prevalence of osteoporosis is decreased from 26 to 5%. But there is a limitation of ICMR data also, because it is done in limited number of patients and only in limited center of India. So we cannot use in the general population. Now there are certain other challenges when we are looking for the BMD report. Like if you see in the left image, this is the normal DEXA scan. If you look for the spinous process, it's almost central. But if you see the right image, there is a deviation of the spine. The spinous process is deviating to the legs. So if there is a rotation in if rotation is there, so we can fastly detect the low bone mineral density. So positioning of patient on the table is very important. So there are other artifacts also there. Sometimes, especially in Indian scenario, what is the problem? The date of birth, many times we are entering in wrong. So that will also affect the results. So this is another pitfall. So once you progress from L1, L2, L3, L4 vertebra, there is a gradual increase in the bone mineral density. And usually, if you see the T-score, the difference in two consecutive spine like L1, L2, L3, L4, the difference should not be more than 1 standard deviation. So if you see this L2, the L1 T-score is minus 2.4, and the sudden at the L2, the T-score is minus 1.3. The difference is more than 1. Then we have to look for any artifact. Like in this case, there is a there is a calcification of aorta that lead to the falsely high BMD. So like in L2 vertebra and also in L3 vertebra, there is an increase in bone mineral density. This is not the true bone mineral density, this is because of the artifact, because of the aortic calcification. See, this is another misclassification. So if you see the reports, so if you see again the T score, like L1 is minus 2.4, L2 is minus 2.9, and suddenly at L3 is 0.4. So if you include this L3, in L3 there is a increased density. This is because of the fracture at the L3 side. If you include this bone mineral density L3, then we can falsely calculate, like if you include this L3 vertebra, then total score of T score is minus 1.8. It is coming in osteopenic range. But when you exclude this L3 from the calculation, like we calculate from L1, L2 and L4 only, then total T score is coming minus 2.5, that is in osteoporotic range. Now the treatment of postmenopausal osteoporosis. So there is two management. One is non-pharmacological, we have to do in all cases, and second is pharmacological management. So non-pharmacological management includes the calcium intake of 1000 to 1500 milligram, but we have to avoid the over replacement also because it leads to the renal stone. And the vitamin D intake at least 600 to 800. Some guidelines they suggest we have to give the higher dose like 1000 units per day. Exercise, stop smoking, and prevention for the fall. Now the pharmacology therapy. So what are the indications for treatment? So if any patient having the hip or vertebral fracture, on X-ray imaging there is no need to measure the bone mineral density to start the treatment. We can simply start the treatment. And if on bone, if on the deck side T score is less than 2.5 at any site like neck of the femur, hip or the spine, we will start the treatments. And if DEXA is coming in osteopenic range like T score between 1 to 2.5, we can calculate the fracs and we look for the 10 years hip fracture if it is more than 3%, and the major osteoporotic fracture is more than 20%. In that scenario, we can start the pharmacological treatment. Now this is the FDA approved osteoporotic medication. So we can categorize into anti-resorptives and anabolics. Anabolics includes the parathyroid hormones, it is 1 to 35, that is teriparatide, or the full length PTH, that is 1 to 84, or the PTH related peptide analog abaloparatide, and this recently, this is the romosumab, that is the sclerostin inhibitor. So basically anabolics increases the bone formation, but after some time it also increases the bone resorption also. So romosumab is unique, it increases the bone formation, simultaneously it also decreases the bone resorption. In anti-resorptive estrogen hormone replacement therapies, they are bisphosphonates, ellen, even and zoledronic acid, and selective estrogen receptor modulator like raloxifene, calcitonin, denosumab. This all available option is there. So I will little discuss what we are commonly using. So like in bisphosphonates, allantonates, so we can use 70 milligram once a weekly because oral absorption is less. So we have to take empty stomach with glass of water, and we have to stand for at least 45 minutes to avoid the esophagitis. And the rigodonate we can use 30 milligram per week. Ibandonate we can use 150 milligram weekly. And it is the only bisphosphonate that is available in oral as well as the intravenous. Ibandonate is not very potent drugs, but there is certain indication where we can use the ibandonate. Like when there is renal function is compromised, and if you want to give the bisphosphonate, in that scenario we can use the ibandonate. And the zoledronic acid, this is a potent bisphosphonate that can be given once yearly. And so what are the other anti-resorptives like denosumab is there that can use the 60 milligram every 6 monthly. and there is beneficial effect on the vertebral, non-vertebral hip fracture. And teriparatide we can use, but this is the injectable, and we have to take daily 20 microgram daily, and it's a monthly cost is around 4,000 per month at least, and that we can use for the up to 2 years. Calcitonin we can use as a nasal spray, but its role only in vertebral fracture. And selective estrogen receptor modulator relaxafil can be used 60 milligram per day. This again only beneficial at the vertebra. And the estrogen and like 17 beta estradiol or hormone replacement therapy we can use. Especially this estrogen we are not using too much, but in certain scenario we are using estrogen, especially when there is a premature ovarian insufficiency, like someone is menopause early, less than 40 years, and there is a bone loss is there. In that condition we are using hormone replacement therapy, especially if patient is not affordable. We can simply use the oral contraceptive pills, and till the age of 50 or 52 years, and if affordable we can use the 17 beta estradiol, but this is slightly costly. We can use the lesser dose like the 0.5 milligram daily. So zoledonic acids we using most commonly we are using the zoledonic acid because it's a potent bisphosphonate, and we can give the once a yearly. The dose is 5 milligram, and we can transfuse over the 15 to 30 minutes. We can do in the daycare facility, and there is a common side effects like the acute phase reaction, like almost 30 to 40% will develop the musculoskeletal symptoms, body pain as well as the fever. So in our routine practice, we are giving paracetamol at least for 3 days when you are giving the zoledonic acids. And these are the recommendations for zoledonic acid we can use for the postmenopausal osteoporosis and the men with osteoporosis, and for the prevention and treatment of the glucocorticoid induced osteoporosis. There is some rare side effect of the zoledonic acids like osteonecrosis of jaw and atypical fracture, but this is it's very rare. If you treat the 10,000 patients of with the zoledonic acid, the chances of osteonecrosis of jaw atypical fracture is almost less than 1 cases, and there is a slight increased risk of the atrial fibrillation. So this is the landmark trial, that is the horizontal, where zoledonic acid was compared with the placebo, and this study was done for the 3 years. So what they have found in this study, over the 1 year, 2 year, 3 years, there is a decreased vertebral fracture is there. Like at 3 years, there is a reduction of fracture by the 70%. And the hip fracture, non-vertebral fracture, again there is a less fracture with the zoledonic acid if you compare with the placebo. The similar effect in non-vertebral fracture, any clinical fracture, clinical vertebral fracture, there is decrease in the zoledonic acid if you compare with the placebo. So zoledonic acid significantly decreases vertebral fracture, hip fracture, as well as the non-vertebral fracture if you give consecutively for the 3 years. And this horizon trial was extended for the next 3 to 6 years. So what they have found, so when the study was extended to 3 to 6 years, so what they have found, there is a still difference in vertebral fracture. So there is a lesser vertebral fracture in zoledonic acid if you continue for the 6 years, but there is no significant difference if you increase the duration of treatment 3 to 6 years in non-vertebral fracture and the hip fracture. So there is a benefit up to till 6 years is there. And again, this study was extended up to the 9 years. Although number of patients is decreased, only 95 patients. But when this period was extended to 6 to 9 years, there is no significant difference in spine fracture, non-vertebral fracture, hip fracture. So zoledonic acid we can give the 3 years, then we can monitor, we can reassess the fracture. If patient is still falling high risk, we can give up to the 6 year. But there is no benefit if you are giving more than 6 years. If you are giving more than 6 years, definitely we are going to increase risk of osteonecrosis of jaw or atypical fracture of femur. Now next potent anti-resorptive drug is denosumab. This is the rank ligand antagonist. This is the study of over 10 years. In the initial 3 years, this is the freedom trial where they have compared the denosumab with the placebo. So what they have found, there is a significant increase in the bone mineral density up to 10% with the denosumab if you compare with the placebo. And this, and when this study was extended up to 10 years, there is a gradual increase in bone mineral density up to 21.7%. And this significant difference is present in almost all the 3 sites like lumbar spine, total leg, femoral leg, and the distal 1/3 of the radius. But what about the fracture risk? So what they found in freedom trial, there is a decreased risk of fracture in denosumab group, like there is 2.3% fracture in denosumab, while in placebo it is 1.2%. When the study was extended to 10 years, again there is a significant difference there in new vertebral fracture, and also in non-vertebral fracture there is a decreased risk in denosumab group. Now what happened when we stop the denosumab? So like in this study they have compared with the placebo. The denosumab was given up to the 25 months, but when they stop the denosumab here after 24-25 months, there is a rapid rise in the bone turnover marker, like CTX is a bone resorption marker, and there is also rapid rise in the P1P, that is the bone formation marker. So when you stop the denosumab, there is a rapid rise in bone turnover marker, and this is also reflected in the bone mineral density also. So when denosumab was stopped, so can I quickly? So when there is a decrease, we decrease the denosumab. When you stop, there is a rapid decline in bone density. So there is an increased risk of rebound fracture. So we have to add, when you stop the denosumab, like we can add the bisphosphonate to stop the rebound fracture. Now teriparatide, this is injectable anabolics. This we have to use 20 microgram daily, and this is injectable. It's costly. We can use up to the 2 years, but there is a contraindication when there is an increased risk of osteosarcoma, like in Prayagraj disease, open epiphysis in kids, and when there is unexplained elevated alkaline phosphatase. So till now we discussed about the anabolics and the bisphosphonates, but if you use the anabolic, it will suppress both resorption as well as the formation. It will stimulate, but when you use the bisphosphonate, it will suppress the resorption as well as the formation. But there is a need of newer molecule that will increase the bone formation, but simultaneously it will increase the resorption. So that is the romosozumab. So that will increase the bone formation, and simultaneously it will decrease the bone resorption. So this is a study where it shows there is a maximum benefit with the romosozumab if you compare with the teriparatide, if you compare with the alendronate. Now this I already explained. Now what is the sequential therapy? When you start the anabolic therapy where you can shift to anti-resorptive, or when you start the anti-resorptive we can shift to the anabolic, or we can start the combined therapy. So what happens, we will combine the anabolic with the anti-resorptive. Like in upper diagram is showing dolidonic acid with the teriparatide, this is showing the teriparatide. So there is no difference in if you use the teriparatide with the dolidonic acid, because the effect of teriparatide is nullified by the dolidonic acid. This is again it's showing this is the peak bone mass achieved by the teriparatide, but when you combine teriparatide with the alendronate, the peak bone mineral density will decrease. This I will skip. So this is the most benefit when you use the anabolic. If you use the teriparatide or full length PTH1-84, or if you use the abaloparatide and followed by anti-resorptive, in that scenario we will get the maximum benefit. Like in this case, the teriparatide used up to the 12 months and followed by the alendronate for the 1 year, there is a maximum benefit in a bone mineral density. This is a newer molecule like romosozumab. They have compared with the dolidonic acid. So what they have found, when romosozumab is followed by alendronate, there is a decreased risk factor in romosozumab followed by the alendronate if you compare with the alendronate.
Dr.
So,
Ritesh, can you please sum up here?
Okay.
Sum up fast.
So anabolic followed by the anti-resorptive, in that scenario we will get the maximum benefit. Like in this scenario, romosozumab followed by the denosumab, in that we can get the maximum benefit. So this is my last slide. If patient fall in very high or high risk, we can choose anyone, bisphosphonate, denosumab, teriparatide or romosozumab. And if patient is intolerant to all the four, we can choose any other drug based on the risk factor like age less than 60 years, less than 10 years of postmenopausal, less thromboembolism, and high risk of breast cancer, we can use the raloxifene. If vasomotor symptom is there, we can use the hormonal therapy. That's all.
Thank you, Dr. Ritesh. It was a nice presentation on osteoporosis. For the benefit of house, can you please make a quick prescription for a 55-year-old lady having had 2 fragility fractures? Just simplified way, what the drugs you will prescribe, routine practice.
Usually I am using sulfuric acid.
You can give the whole list of the drugs what you prescribe for a osteoporotic treatment.
Because it's 50 years old female, postmenopausal, having already fracture is there. In that scenario, anabolic is best. If patient is affordable, we advise the teriparatide at least for 1.5 to 2 years.
Okay, teriparatide.
Second, we can use the bisphosphonate. We can use.
Okay, which one you prefer?
Usually prefer sulfuric acid.
Once a year for 3 years. Calcium, how much?
Calcium we are giving all patients we are giving 1000 to 1500.
Calcium carbonate or citrate?
Usually I use calcium carbonate.
Okay. Vitamin D?
Vitamin D usually coming in strength. We have to replace the vitamin D before starting this teriparatide or using the bisphosphonate.
So, and anything else like the molybdenum and the selenium and zinc and the micronutrients? We are all, they have been, and high protein diet or anything specific?
We don't prescribe anything other than calcium, vitamin D and specific treatment for osteoporosis.
Okay. And how frequently you follow them up?
Usually in our center we have hyaluronic acid, so once yearly we are doing bone mineral density before giving the hyaluronic acid.
Okay. Thank you so much.
Being a gynecologist, I will just say that HRT should be used by the gynecologist, so that because they know all the risks involved with HRT.
Madam, we are using very frequently, especially in endocrine clinic, the oral contraceptive pills for our endocrine causes as well as for the this osteoporosis.
But we have to see the history of breast cancer, endometrial cancer, history of hysterectomy, everything.
If you are giving long duration, we have to keep surveillance at least.
My question is that what is the difference in the progression of osteoporosis in cases of the natural menopause and surgical menopause? We come across the patients who has been uterus removed at age of 30, 35.
So
I think I should answer this question. In these cases, in surgical menopause, we have to give HRT, but it has to be given by gynecologist.
Sir, there is a medical cause of premature ovarian insufficiency as well as a surgical cause. So when there is a premature ovarian insufficiency like 35 years, 40 years, we are giving hormone replacement therapy till the at least 50 years to achieve to gain this bone mineral density.
But the only thing is by gynecologist.
Yes.
Thank you.
Any questions from the house for the discussion purpose? Dr. Ritesh, I have got a question. Being a neurosurgeon, we actually encounter with osteoporotic fractures. For that, we are already doing minimal invasive treatments in the form of vertebroplasty, kyphoplasty, and minimal invasive fixations as well. But nowadays, what I am seeing that we are encountering osteoporosis in young age population quite often. what is your scenario? Second thing, do you think there is some relationship of this consumption of mineral water or RO water with osteoporosis?
So I don't think so, sir. So earlier, like fluorosis, all are common, but that can be due to the increased bone mineral density, not the osteoporosis. But even increased bone mineral density in the fluorosis, there is increased risk of fracture because bone quality is not good if you do the bone histomorphometry. But I don't think by consumption of RO plant will increase the osteoporosis risk.
Thank you so much for your visit, doctor.
Everybody is looking forward for the next lecture on obesity, particularly I am.
I would request Dr. Sujit Singh sir to please come on the stage and honor the speaker. I would request Dr. K.D. Tripathi sir to please come on the stage. I would request sir to please provide the certificates to the chairpersons.